what's up, everybody? Hey, welcome to the show. Welcome to the broadcast. My name is Sean, and if you are new to this channel, I am a flight paramedic in Colorado, and I run the Medic Lab here. And today we're going to be talking about, we're going to be continuing my discussion on the National Association for EMS Physicians' recent publication of new position papers on the topic of prehospital airway management. If you have missed the previous couple episodes that I've done, you can check them out in the channel here on YouTube. So with that, again, I just wanted to kind of introduce myself. My name is Sean. I'm a flight paramedic and critical care paramedic here in Colorado. And if you want to find out some more information about me, you can you can check out my website, flightcrit.com. Anyways, with that said, here we go. Today, we are going to be talking about the latest publication. This was published in the Prehospital Emergency Care Journal. This was a supplement to the January edition of the journal. And the National Association for EMS Physicians, they put out basically a compendium of 18 new position papers on prehospital emergency airway management. And so today we're going to be talking about optimizing physiology. And I really, really enjoyed this particular paper. I went through and made a ton of notes here, and I really want to kind of delve in and talk about what they put in the paper, and then some of my comments about it. I have had a fairly robust experience with this topic of optimizing physiology in the prehospital setting. It's something that I did not always do in my practice, but probably in the last 5 to 10 years has definitely been a focus of my attention in managing prehospital or managing the airways in the prehospital setting. So with that said, let's dive in. So as we scroll into the paper, of course, they always start off with the abstract, which is just kind of a summary. And in this particular case, right, the big focus here is on the prevention and or correction of hypoxia and hypotension during prehospital airway management attempts. And the importance of perfusion, oxygenation, and ventilation for our prehospital patients. As we move into the paper, we're going to talk about some specific concepts with regards to optimizing physiology. Some of these are going to be directly applicable to the prehospital setting. Some of them will not be. And so I do have a little bit of reservation about this introduction to some of the topics that they talk about. Not that I think that they're wrong, but I'm concerned that from a prehospital setting, non-critical care prehospital setting, some of these concepts are going to be impossible for providers to actually implement. So with that said, let's go ahead and start scrolling down. So I highly recommend that you go and actually read this paper yourself. I'm not going to be going through the entire paper. What I'm going to be doing is hitting on some of the highlighted portions of the paper or key topics that I feel are of particular value, and that I have something that I want to kind of contribute to, right? I'm not going to read the paper because you can do that yourself. But what I want to do is open up a conversation and add to the discussion about these papers. So if you, I will put a link in the comments after the broadcast. If you've seen some of my previous broadcasts, you know where you can find these papers. But if you actually just go online and you search Prehospital Emergency Care Journal, NAEMSP Airway, it will pop up. All 18 of these are currently open source, and they are available for anybody to check out. At some point, they will be published on the NAEMSP's website, but as of a couple days ago, they were not there yet. So, anyways, as we dive in, right, airway management involves complex series of cognitive and psychomotor skills. And I think that this is very important because historically, we really focused on the skill aspect. How do we actually hold the handle? How do we introduce the blade into the mouth? How do we actually pass the endotracheal tube through the cords? How do we, utilize this concept of the salad maneuver, right, to suction the airway and clear it out, to decontaminate it? But there is a cognitive component to airway management that I think we are failing at. We are not focusing our attention from an education and training perspective on thinking about the process of airway management, thinking about what is going to be the best way to manage this patient's airway. Is it to bag them? Is it a supraglottic airway? Is it to place an endotracheal tube? What can I anticipate are going to be some of those problems as I work through this procedure? And so we need to be thinking more outside the box and planning ahead. This is not just a rote skill procedure of placing plastic through the cords. There's so much more to it. And this particular paper really highlights that when they start talking about optimizing and managing oxygenation and hemodynamics, kind of the whole physiology of the patient prior to and during the intubation attempt. Right, so we are managing the physiology, and they even introduced this concept that we utilize in the cardiac arrest setting, this pit crew concept, right? They kind of share, kind of introduce that idea into the process of airway management, and I think that there's some value in that. It's a little more complicated because the management of an airway is, I feel, much more dynamic. It's very dependent on the patient's specific presentation. What is their hemodynamics? What is their oxygenation status? What is their physiology? What is their anatomy, right? Whereas in a cardiac arrest, it's pretty straightforward. It doesn't mean that there is not value in this concept of pit crew approach to airway management, but we need to think about how we can apply that to the airway management setting. One way that we can do this is through this this process here of communication, leadership, team coordination, and decision making. When we are presented with a patient who requires airway management, whether that is somebody in full cardiac arrest, whether that is somebody who's in respiratory arrest, they're hemodynamically compromised, they're having a stroke, they need airway protection, they're a major trauma patient, we need to start thinking about all of these things as a kind of a holistic approach to the patient care, right? Somebody's going to have to be the team leader. Somebody's going to have to be the actual airway clinician, if you will, the one that is actually performing the placement of the tube. Somebody needs to be record keeping. Somebody needs to be monitoring the patient's physiology. There needs to be this communication. And when we think about the leadership versus the actual person placing the tube, they may not be one and the same. It becomes more complicated when they are one and the same. When the person who is the most experienced airway clinician, the one that is most experienced at actually placing, doing the laryngoscopy and placing the endotracheal tube, is also the senior person or the most skilled person in managing that particular scene. So in that setting, it may or may not be appropriate to think about switching roles or delegating roles to somebody else, right? And when you are working with a nurse or another medic, and you work closely together and you train together and you educate together, making that switch can be very easy. But if you're in an environment where you are constantly working with different partners, it may be a little bit more challenging. So just kind of anticipating that going into this airway. I really like that they mentioned here this concept of verbalization of the airway management plan. I've had really good success in doing that, where I'm in the back of an ambulance. I've got my EMS crew with me, I've got my partner with me, I'm at the head, and I'm actually talking through this process whereby I'm saying, this is what we're going to do. We're going to position the patient. We're going to put the nasal prongs on. We're going to pre-oxygenate them. I'm going to start with a non-rebreather mask. If that's not effective, I'm going to switch to the flow inflating bag so that I can deliver effective positive and expiratory pressure, or PEEP, to the patient. We're going to use these medications. You draw them up. This is what we're going to use for post-intubation management. Is the patient's, are the patient's vital signs stable? Do we need to consider fluid resuscitation? Do we need to start a pressor on this patient? Do I have push dose pressors available? Here's my push dose epinephrine. I'm going to give the patient a little bit of a, excuse me, a bump right before we actually do the procedure. If my first attempt is not effective, and I go in and I see something that I'm not expecting, these are the changes that I'm going to consider. I might go to a different size tube. I might change the blade. I might go to direct laryngoscopy. I'm going to use the bougie, although now I pretty much use video laryngoscopy with the bougie on every attempt, first pass. If that's not effective, if I have to go to a surgical airway, or if the intubation fails, I'm going to go to my supraglottic airway. If that doesn't work, I'm going to go directly to surgical airway. And I verbalize that. And what that does is that puts everybody on the same page. Everybody knows the plan. This is how we're going to proceed if this airway doesn't go as anticipated. If I'm seeing things that give me pause or give me concern about my ability to place this, whether I think it's going to be a difficult intubation or not, I will verbalize, hey, I see that this patient has a collar on. Yeah, this is going to complicate this. I'm going to hold manual C-spine, or you're going to hold manual C-spine. I'll delegate. You're going to hold anterior C-spine. You're going to flop the collar so that I can have good manipulation of the mandible. All of these things get verbalized, and I really like the fact that they put that in their recommendations. Cognitive decision making is important, and we really do need to focus on this, right? And this is where those non-technical skills come in. They talk a little bit here about training, and I've talked about this in previous broadcasts where we need to focus on the micro skills. How do I advance the blade into the patient's mouth every single time the same way? How do I advance that bougie? How do I manipulate the coude tip on the bougie so that I get it in the direction I want? If we practice these micro skills and then we put all of them together into a scenario, we find that the application of the whole skill improves substantially. There's also this idea, and they touch on it here a little bit, but I wanted to kind of highlight this personally, is that often we go into our training scenarios and we're asked to work through a scenario, and we work through it and we debrief and then we're done, or we go on to another scenario. I would challenge you, if you are an educator or if you are in a position to be able to be part of the planning phase, is think about this concept of perform, debrief, do it again, right? If we can get repetition, right, we can go through a scenario, we can perform it, and then we can debrief it, and we can break it down and go, oh, what could you have done better? Oh, I could have positioned my bag better. I could have talked more. I could have laid out my airway plan a little bit better. And then you redo the same scenario and you apply those concepts. You apply the information that you just learned during that debrief to the same scenario again, and you improve. And then you debrief it again, and you do it again, and you do it again. And if you can back to back to back, you run the same scenario back to back to back, you can actually see exponential gains in your confidence, the confidence of your providers, your clinicians, as well as their skill retention and their cognitive reasoning through the process. You can throw in some curveballs as they advance through the scenario, something that kind of throws it off a little bit, and now they have to stop and they have to think. This is not just about moving forward with the scenario, but now they need to stop and think, what do I need to do now in order to better manage this patient? Okay. Some other things they talk about, decontamination using suction, and this is all about approach to pre-oxygenation, right? And they talk about using a nasopharyngeal or oropharyngeal airway, passive administration of supplemental oxygen. We've all learned about the no DSAT concept, right? At this point, we should all be pretty well versed in what that means. The use of nasal prongs, high flow to wash out all the nitrogen and to pre-oxygenate our patient. Administration of supplemental oxygen, airway decontamination. Of course, we need to clear out the airway so that we have the ability to deliver oxygen to the lungs during the intubation process. The use of positive pressure, and they talk about via high flow oxygen. Be careful of the device that you use. If you are using a standard nasal cannula, or even worse, a end-tidal CO2 cannula, you cannot deliver adequate high flow to the patient. Now, I would say, maybe I should rephrase that a little bit. A normal nasal prong will deliver high flow, but once you get above that 12 or 15 liters per minute, the flow through the prongs is pretty turbulent, and you don't actually start delivering pressure into the airway. If you have the ability to utilize something like the RAM cannula, the bore is larger, they're designed for much higher flows, and you can get more laminar flow and more pressure into the lungs and actually provide better pre-oxygenation. So just some things to think about. They go on here to talk about secondary injuries, okay? And this is an extremely important concept. The concept of preventing secondary injuries from hypoxia or from hypotension. And the big one I would say is hypotension. When we start advancing down the path to placing the endotracheal tube, if the patient is even borderline hypotension, we need to correct that. Because if we don't, the mere process of intubating a patient will likely drop their blood pressure even more and result in undesirable sequelae. Right? So things that can drop a patient's pressure during the intubation attempt, right? If you are treating them pharmacologically with sedatives or analgesics, you are taking away their sympathetic drive. Even if you are using ketamine, ketamine will also drop a patient's blood pressure because of the same effect. It has a tendency to take away that sympathetic tone. Now, that being said, ketamine is a sympathomimetic. It will give them a little bit of a sympathetic bump, but I would argue that it's not enough to combat the decrease in sympathetic innate or in intrinsic sympathetic drive that somebody is experiencing when they are in extremis. So that being said, even if you are using something that is considered hemodynamically stable, like etomidate or ketamine, you still need to anticipate the patient will drop their blood pressure. Okay. So how do we, before I move on, other things that will do that, just the transition from negative pressure ventilation to positive pressure ventilation will also decrease right ventricular preload and can decrease a patient's blood pressure, right? So all in all, if you've got this patient who is borderline hypotensive, you need to treat them before you actually intubate. It's this concept of resuscitate before you intubate. So make sure you've got good lines, give them some fluid, give them some oxygen, give them some pressors. If you have it in your guidelines to have push dose pressors available, have them ready. If not, have your vasopressors on the pump, or do your dirty epi drip if that's what you have available to you. Start that pressor ahead of time. Get their blood pressure up. Get some peripheral vessel squeeze so that you are ahead of the game when you start introducing these mechanisms or these drugs that are likely going to drop your patient's blood pressure anyways. All right. Let's go ahead and move on to the next concept. Decision-making, timing, and duration of airway attempts. All right. What I really want to say about this is not a whole lot. It used to be taught that we should only intubate in 15 seconds. Not so much anymore. If your patient's physiology allows it, if your pre-oxygenation strategies have worked, if your nasal prongs are in place and you are getting adequate passive oxygenation, it can be acceptable to attempt your intubation or extend your intubation attempt longer. Okay, the goal is to be monitoring their physiology, monitoring their oxygenation, monitoring their blood pressures, and not allowing those to drop. In here, they talk about the use of continuous pulse oximetry. The risk of relying on continuous pulse oximetry is that it is delayed, especially in that hemodynamically compromised patient. It can be delayed, 15, 30 seconds, even up to a minute. So while it is the only thing that we really have available to us to monitor O2 sats in any real setting, understand there are limitations to the pulse ox. And so monitoring your heart rate can be a late but more, how do I want to say this? It's not a more effective use for monitoring oxygenation, because if your patient's already starting to brady down, you are well behind the curve. Just understand that if you are waiting for the pulse oximetry to start to drop before you start recognizing the patient is becoming hypoxic or hypoxemic, you're behind the game, right? You need to have a strong understanding of the oxyhemoglobin dissociation curve and how the curve drops off, becomes much steeper after about 94%. So in this guideline, they're saying that your goal is to maintain a pulse oximetry between 94 and 98%. After 94%, you should be backing out of the airway. And I would say that that's probably fairly true, fairly accurate, because if you are allowing that pulse ox to drop beyond the 94% range, then you are well into the steep curve portion of the oxyhemoglobin dissociation curve, and your patient's PaO2 is starting to plummet rapidly. What I would say is, during your training, think about starting to anticipate having to back out of the airway and reoxygenate the patient if their sats are closer to 96, 95. Okay, that's going to give you a little bit of wiggle room, so that by the time they hit 94%, you're already planning to back out and reoxygenate that patient. Okay, end-tidal CO2, absolutely. We all know that we have to utilize end-tidal CO2 for monitoring the tube placement. You can also utilize end-tidal CO2 during the pre-oxygenation state. What I like to do is actually have the mainstream capnometry attached to my flow inflating bag, so that as the patient is breathing out, I'm monitoring their CO2. That helps me make sure, one, that if I do have to actually bag them, that I'm not bagging them too fast. It's also right there ready once the patient is intubated, already connected to my bag. But it also allows me to monitor how well I am resuscitating that patient prior to my intubation. Now, this is kind of out the window if we have a patient in cardiac arrest, but in a patient who I am intubating them because of either clinical course, or they're in a big stroke, or they're a trauma patient, I can tell how well I have resuscitated them based on my CO2. If they're not if they're not off gassing CO2, if my end tidal CO2 is really low, and the patient's respiratory respiratory rate is relatively normal, they either have a big shunt, but I can kind of try to figure out what that's from. So do I need to give them more fluid? Do I need to give them more blood? Do I need to give them more pressors? Do I need to resuscitate them more before I actually go ahead with my intubation? Failed ventilation was detected by capnography, waveform, retrospective, and not by the treating EMS clinicians. This was a comparison between, well, basically what they're saying here is that even when we are utilizing end tidal capnometry to monitor our airway, there are still incidences where we as clinicians are failing to recognize that our patient's respiratory drive or their hemodynamic status is declining. We have the data. What they're saying is that the monitor is collecting the data, it is collecting the waveform, it is collecting the capnometry, but we are failing to recognize the decline in the patient's status, and retrospectively they can go back and pull that data and look at it and see right here it's very clear that your patient was decompensating. There was an interesting meme that I saw recently. It said that patients don't suddenly decompensate, that clinicians suddenly recognize their decompensation, right? Or that they've already decompensated, right? And so understanding that our patients are always going to give us clues, we need to be paying attention to all of our monitoring equipment. Just because we have the patient intubated and on the ventilator and we've got them hooked up to end tidal, that does not mean that we can now relax. We need to continue to monitor them, and we need to support their hemodynamics after the intubation, whether that is with pressors, fluids, bloods, optimizing their post-intubation sedation package, synchronizing them to the ventilator, making sure that our ventilator is actually programmed correctly, or that we are providing manual ventilations appropriately. And they go into the differences there in this paper. Optimizing perfusion and oxygenation and ventilation in the post-intubation setting. So I want to zoom in on here because I had quite a few notes here that I wanted to comment. EMS clinicians should achieve systematic normal oxia. Okay, and this is where they talk about what is our goal for oxygenation, whether it is patient on the ventilator or patient that we are bagging. Between 94 and 98. There are some caveats here to their recommendations. They're talking about the post-head injury patient. They might do better if we are bumping their oxygenation status up a little bit, or their PaO2 up a little bit. But generally speaking, 94 to 98. These really severe ARDS patients, we will, especially in the era of COVID, if we can get them to 88 to 90, we're happy with that. We're not necessarily talking about that particular patient population, but in general, what we're saying is 94 to 98 is appropriate. If you've got a patient with a SpO2 of 100, their PaO2 could be super therapeutic, which could actually cause more damage from the oxidative free radical effects that we're starting to see from these higher concentrations of oxygen. They do talk here about how we can optimize or reverse their hypoxemia, increasing alveolar surface area through the administration of PEEP primarily. They talk about tidal volumes, although I would argue that tidal volumes is not the best way to optimize your alveolar recruitment, although there is some concept, or there is there's some truth to that. If you are severely under ventilating your patient with tidal volumes far below adequate, you will get atelectasis and hypoventilation of the lungs, and so you're not going to get gas exchange. And so there is some truth to that, optimizing your tidal volumes in that 6 to 8 mLs per kilo range. But primarily increasing your FiO2, increasing your inspiratory time, which prolongs your mean airway pressures, and then PEEP to prevent atelectasis and atelectatic trauma and improve oxygenation. In the ventilator management class that I teach, we talk about Fick's law and how we utilize PEEP to increase the surface area of the alveoli, recruit those alveoli, and then thin the wall in order to increase oxygenation. Optimizing perfusion, right? We need to optimize the patient's blood pressures so that we get good blood flow to the lungs for adequate oxygen exchange. And then they talk a little bit about positioning the patient and how somewhere around 45 degrees is good for preventing ventilator-associated lung injury and ventilator-associated pneumonia. So if you're if it's not contraindicated, it's best to sit your patient up. That's going to help position the lungs better so that they can oxygenate and will prevent some of these sequelae that we cause, right? These iatrogenic effects that that result from the care that we provide to our patients. Talking here about hyperventilation, right? We know hyperventilation is generally bad. End-tidal CO2s should be somewhere, or PaCO2, normal PaCO2 is between 35 and 45. And so they're saying that we should target a PaCO2 of 40. Well, likely you're not going to have access to blood gas administration. And even if you do, you're likely not going to be drawing arterial blood gases. You might be doing venous, right? A better approach is to target an end-tidal CO2. Here's the thing though, end-tidal CO2, especially in your severely compromised patient, is not going to correlate exactly with your PaCO2. What do I mean by that? There's usually a 3 to 5 point difference between your PaCO2, which is your partial pressure of arterial CO2, and your end-tidal CO2. The end-tidal CO2 is usually 3 to 5 points less than your PaCO2. In the patient in shock, that difference, that PaCO2 end-tidal CO2 ratio gets bigger. The patient will never have an end-tidal CO2 higher than their PaCO2, right? It's just impossible. You can't be blowing off more CO2 than your body is actually producing and is storing in the blood. So your end-tidal CO2 will always be lower than your PaCO2. So in the setting of an intubated patient or a patient that you're bagging, if you are concerned that they are profoundly acidotic, it's best to target a slightly lower end-tidal CO2, knowing that your PaCO2 will be a little bit higher, okay? So if our goal is to have a PaCO2 of approximately 40 or 35 to 40, generally speaking, what we will say is unless we can actually draw a blood gas, determine what their end-tidal CO2 is, at the same time we're determining what their PaCO2 is, and figure out what that ratio is, they will generally trend up and down together. Unless we can actually determine what that ratio is, we will usually target a slightly lower than physiologically normal end-tidal CO2. So somewhere in that 38 range, because we know that their PaCO2 will always be higher than that. And that's what they're talking about. Okay. Patients with metabolic acidosis but without brain injury may require a lower PaCO2 target to provide partial respiratory alkalosis. If your patient is in a state of metabolic acidosis, meaning their pH is below that 7.35 to 7.45 range, but it's from a metabolic process, we compensate with the respiratory drive in order to correct that pH, right? And so just keeping that in mind, that if you have a reason to think that your patient is in a state of metabolic acidosis, you will probably want to drive that end-tidal CO2 down just a little bit more in order to try and help compensate that patient. Keep this in mind though. If you have a patient who is tachypnic, who has a low end-tidal CO2, and you have reason to suspect that they are in a state of metabolic acidosis, when you decide to intubate that patient, you must match their minute ventilation, which means you must match their volume and their rate, because that patient is compensating. If they have already become, their respiratory rate has dropped, they've become bradypneic. I can never say that word right. Doesn't matter. You know what I'm saying. If their respiratory rate is dropping, it's probably because they're becoming fatigued. It is vitally important that you maintain their minute ventilation if they are in a state of respiratory acidosis. Whether you are putting them on a ventilator or you are bagging them, if you do not, if you say, I've now intubated this patient who is breathing 30 times a minute and now I'm going to bag them at 12, their CO2 will climb and they will likely arrest because their pH will continue to drop. So just keep that in mind. Using push-dose vasopressors prior to intubation is a skill that we should all have available to us. If you don't, think about bringing that to your quality improvement committee. When we have these patients who are hemodynamically unstable and we are going to intubate them, this is outside the setting of a cardiac arrest. We need to have the tools in order to optimize their physiology prior to intubation. All right, what else do we want to talk about here? Strategies to mitigate aspiration, that's sitting the patient up, making sure that we are suctioning their airway. I did want to talk about one thing back here. They talk about, in here, the use of supraglottic airways, and how that is sometimes a BLS skill. But that these providers who are placing these supraglottic airways are hamstrung by the lack of ability to utilize capnometry. There is no reason why, in my mind, there's no reason why we can't train our BLS providers to be able to hook up capnometry and interpret what the numbers and the waveforms mean if we are giving them the skills of placing a supraglottic airway. We still need to be able to monitor these patients' airways. We still need to monitor their respiratory drive. We still need to get some information that can be gleaned from that supraglottic airway and the end-tidal CO2 waveform. So if you work in a program where your BLS providers are authorized to place a supraglottic airway, train them to place the patient on end-tidal CO2 and monitor that waveform and monitor that numeric value and understand what that means. What else here? Tidal volume, we already talked about that. They talk about here hyperventilation results in hypotension. Patients with acute respiratory distress syndrome or ARDS and multi-organ dysfunction syndrome benefit from low tidal volume ventilation and permissive hypercapnia. These are more advanced concepts. They're very challenging to utilize or to kind of address when you are manually ventilating a patient. So these are more advanced concepts that you would need to know about if you are using pre-hospital mechanical ventilation, which is what I talked about last week. We looked at the position paper from the National Association for EMS Physicians on pre-hospital use of mechanical ventilators. One of the things that they talk about here in this paper, as well as in the previous paper, is the use of ideal body weight to determine appropriate lung protective strategy. Here they talk about 4 to 8 mLs per kilo. The ARDSNet guidelines talk about 6 to 8. You can go down as low as 4 mLs per kilo of ideal body weight, but that's in those severely ARDS patients. In order to optimize ventilation, 6 to 8 mLs per kilo is your appropriate tidal volume, right? So unless you have the patient on a mechanical ventilator, you're not really going to be able to monitor that. So it's very important that we continue to retrain on these basic skills of bag valve mask ventilation, or what I advocate for is use of the flow inflating bag. The flow inflating bag, particularly in a patient who we are preparing to intubate, has a lot of benefits. We can monitor the airway pressures during our peak inspiratory pressures during ventilation. We can deliver CPAP because it doesn't have the valve. We can really feel the patient's compliance. And so utilizing a flow inflating bag, particularly before putting a patient on a mechanical ventilator, is really going to give us a lot of information that we would not be able to glean from the use of a standard BVM. And if we are pre-oxygenating a patient right there with that same device, we can deliver CPAP and then switch directly over to bagging that patient once they are intubated. They talk about the use of PEEP and how PEEP is often underutilized in the pre-hospital setting. And I will tell you that I've seen that firsthand. If your program is utilizing PEEP valves, strong work. If you're not, get them. If you, particularly if you are utilizing a self-inflating bag, which most EMS agencies are utilizing. If you have the ability to get flow inflating bags for certain instances, they are very beneficial, particularly with pediatric patients, or if you were just trying to pre-oxygenate a patient who has spontaneous respirations, they're fantastic. Otherwise, utilizing a PEEP valve on your BVM is essential and should be standard, kind of is standard of care and should be common piece of equipment in any of your resuscitation bags. Last thing they talk about here is use of anxiolytics, amnestics, and analgesics in the post-intubation state. What I will tell you is that giving a little bit of analgesics can go a long way to making your patient more comfortable with the tube. Now, again, this is talking about those patients that are not in cardiac arrest. These are the patients that are in respiratory failure, stroke patients, MI patients, trauma patients. We don't like to, historically, we have been afraid to manage our hypotensive trauma patients with analgesics. But what I will tell you is that these patients do so much better when we can treat their pain, provide the appropriate airway management, and then resuscitate them, right? So don't allow your patient to be coughing on the tube, to be, anxious, to be in pain, to be, have this big sympathetic surge because you're afraid of dropping their blood pressure. If we go back to what we talked about in the beginning about optimizing our patient's physiologic status prior to doing the intubation, resuscitate before you intubate, our patients should be more hemodynamically stable, and we should have that wiggle room in order to treat their pain and their anxiety appropriately. I highly recommend that you get used to, treating their blood pressure with blood, fluids, pressors as necessary. Don't withhold appropriate care just because you're afraid of their blood pressures or the physiologic status. Treat their airway, treat their pain, treat their blood pressure. They all work synergistically to provide the best level care to our patients. We don't want to withhold one for fear of affecting the other one. Treat it. Treat the side effect. If the side effect of giving somebody a little bit of fentanyl because you've intubated them and they're now in pain, if the side effect of giving them that fentanyl is that their blood pressure drops a little bit, then you need to resuscitate them better. You need to give them more fluid. You need to give them more blood. You need to give them a little bit of pressors. Hang that dirty epi drip if necessary. Give them, a push dose epi. If they are bleeding, give them more blood. Stop their hemorrhaging. Do whatever you can. That's all I have for this paper. I hope that you found this kind of enlightening. I'd love to hear your comments. So if you have comments, put them in the comment section below and I will read those. And I will be back not next Monday. I'm going to be out of town, but we'll follow back up with Tuesday. Tuesday is usually my day to just kind of work in the office, go over papers, kind of come up with a game plan. But I'm going to be away from the office on Monday, so come Tuesday, I'll be back here with another broadcast. If you have any questions, comments, or concerns, anything that you'd like to see here in the Medical Lab, please leave them in the comment section below, or you can shoot me a message. And if you like this kind of video, please, subscribe to the channel, give me a thumbs up, hit the bell, and you'll be notified the next time we do a broadcast. Thanks, everybody. Sure hope you enjoyed this, and we will catch you on the next episode or the next broadcast. See you later.